DSEC. He has multiple publications under him. We have Dr. Vinay Pillai. He is a senior consultant of cornea and refractive surgery at Giridhara Eye Hospital, Kochi, medical director of Swarnam Eyebank. And we have Anita Jabba, madam. She's a chief cornea and anterior segment consultant at Little Flower Hospital, Angamali, the senior consultant of cornea and refractive surgery at Eye Vision Eye Care Hospital, Chalakudi. Dr. David Pudkadan, he is cornea consultant in refractive services, working at Netra Eye Hospital, Irnyalakuda. He is a former medical director of Eyebank and the former cornea consultant of Little Flower Hospital. And myself, cornea and cataract surgeon in Little Flower Hospital, medical director of Eyebank Association, Kerala, and cornea subcommittee member. Coming to the topic, historical perspective in Eyebank organization. As Shakespeare rightly said, the eyes are indeed the windows of the world and windows to the soul. It's very important to protect eye and vision. Cornea blindness ranked third among the world blindness after cataract and glaucoma. Nearly 10 million people are bilaterally blind. According to RAP's survey, 37.5 people are blind in 0 to 49 years, and it's the second most common cause of blindness, more than 50 years. There's a big problem, and the only solution what we have is corneal transplant, and the most common transplant surgery done worldwide. And this is the importance of Eyebank. Eyebank plays a very important role in both effective, qualitative and quantitative corneal transplant. There's a considerable shortage about the availability of donor cornea, nearly 1 cornea for every 70 required, and we need minimum collection of 2 lakh tissues to perform 1 lakh corneal transplant annually. Coming to the history, we know Dr. Edward Conrad's film started corneal transplant in 1905. As the history says, a 45-year-old farmer suffered from Lyme's injury and an 11-year-old boy suffered from Penttering injury had come at the same time, and his both corneas were transplanted to the farmer. This is a photo of Edward Conrad's performing surgeries, and you can see eye in the moist chamber. Though the history says the corneal transplant was started in 1905, but still there was a very less number of transplantation happening. That's because from the retrieval from the donor to the recipient, there was a shortage time and effective transplantation was not occurring. That's because we were lacking storage media. And that's the time when Tony Patton realized the importance of storage medium, and he started Eyebanking. In 1944, the world's first Eyebanking was started, known as Eyebank for Sight Restoration at New York, now known as Manhattan Eye and Ear Throat Hospital. If you see history, along with 1955, we have 27 ophthalmologists representing 12 Eyebanks started American Academy of Ophthalmology and Odontology, and then a committee of Eyebank was formed, and Tony Patton was chairman. In 1961, Eyebank Association of America was formed. This is a photo of Tony Patton with his colleagues during the formation of the committee. This is a photo of the first ever pledge form for eye donation. Along with Tony Patton in history, there was one eminent personality known as Ida Breckinridge. He was there in every step of Tony Patton. She realized the importance of social media press. She used to collect all the emotional stories of the patients who received the donor cornea and got vision, and she used to put it in newspapers, publish in articles, then known as New York Times Magazine, Reader's Digest, had all the information and the stories related. And public started knowing about it and directly increased the eye donation. She realized if the stories has to pass countries, she collaborated with Eastern Airlines, and Reader's Digest magazine was kept in every seat of the traveler. So people who traveled in flight used to read the stories and pass on the information. Coming to the history of India, we have a very rich history. Noble and selfless practice of eye donation was actually mentioned in ancient times, in ancient history. The legend Kanappa Nair, he's a hunter, and during his travel in forest, he saw Lord Shiva's eyes bleeding, and you can see the photo depicting with an arrow, he plucks out his eyes and donates to Lord Shiva. So the idea of donation, eye donation was there in ancient history, in texts. In 1945 was the first eye bank, which was formed in Madras Eye Infirmary, now known as Regional Eye Institution of Ophthalmology, by Dr. R.A.S. Muttaya. He had performed his first corneal transplant in 1948. The Regional Institute of Ophthalmology, Chennai, was the oldest eye hospital in Asia and the second worldwide. The first eye bank was 1944, and we had our own eye bank in 1945, 1 year later. So we were very strong in ophthalmology department. In the history of 1960, we had Professor R.P. Danda and as well as Vasundhara Kalaver, who had started corneal transplant at Civil Hospital. There's a walk down memory lane of Dr. Vasundhara Kalaver. She was the first female corneal surgeon in India. The photo of Dr. Vasundhara and Professor R.P. Danda during the All India conferences, and the photo of the first few corneal transplants presented. Coming to history of Kerala, one of the smallest state but richest history, our Eyebank Association Kerala was started in 1970 in Little Flower Hospital under the guidance of Dr. Tony Fernandez. If you see the timeline domain, in 1976 was NPCB, which was established. By 1985 onwards, screening program for HIV and HPCG had started. In 1994 was the Transplantation of Human Organ Act established. In 1994, there was a one big milestone of MK Media being prepared widely at Ramayam International Eye Bank as well as Rotary Arvind International Eye Bank. And then the latest addition in the timeline is 2018, the Central Motor Vehicles Act, in which they have made it compulsory for willingness of donation to be mentioned in driving license holders. So every person who is holding the driving license will directly donate, are donors. So this has been implemented as of now only in 3 places: Rajasthan, Gujarat, and Chandigarh. It's not yet come to South India. So evolution over the past 6 decades shows tremendous history, and India stands one of the toppest in eye-banking system in the world. Coming to the eye-bank system, when you say about eye-bank, it includes corneal donor screening, eye-bank corneal retrieval, storage, evaluation, distribution, and the entire thing together is known as system, and every topic of this has been dealt by our eminent speakers today. In Eyebanking, we have 3 tier actually in the pyramid. The first one is the Eyebank Training Center, which has been established in RIOs. Then you have Eyebank at medical colleges and tertiary eye care center. Then you have Retrieval Center, the donation centers. Those will be the hospitals with a mortality rate more than 50. It's very important to know that the collection center cannot work alone. It should be always collaborated with the training center as well as Eyebanks. The members included in Eyebanking will be the board of directors, which includes the chairman, treasurer, secretary, a medical director, advisor, and it all works under an umbrella effect. You have board of directors, under that you have a medical director, then you have an Eyebank in charge, and you have the staff and technicians included in every step: recovery, screening, preparation, storage, and distribution. SOP, Standard Operating Protocol, should be established in every Eyebank, and this should follow the protocol of NPCB guidelines and as well as Eyebanking India guidelines. So what is the basic difference among the 3 tiers of pyramid? I'll just highlight the important points. When you're in collection center, you need an in-charge person as well as a counselor, but you don't need a board of directors or medical director in a collection center. Related to the equipments, you need a 24 hours working refrigerator as well as you need instruments for cleaning and storage for a collection center. But when you see a slit lamp, microscope, then you have a specular microscope, you have lamellar flow head, autoclaving, all these are not required for collection center, but is required for the tertiary care center and Eyebank. Now, how do you register? It's been registered under 1994 Transplantation Act and 2014 HOTA registration. The form is Form 15. Collection center, there is no need for registration under HOTA registration, but should be informed under health authorities. Initially, all these protocols used to take place directly with NPCB. Now we have a system called as KSOTO, Kerala State Organ and Tissue Transplantation Act. Myself and Anil sir are the members of KSOTO of Kerala State. And now we have the certificate of Form 16 is a certificate what we get after the application, and Form 17 is for renewal. The most important step or the most important backbone of eye donation is not the system alone. System, yes, we need, but the most important step is awareness. So bringing awareness is important step for Eyebanking itself. Just because my topic is history, I would like to put the last slide. The first National Award winning Kannada movie, it was in 1954, was based on eye donation, and it was transferred in different languages. So the public could ratify it and agree to it, and the movie ran around 365 days. This is important because we verbally talking about it may not reach the public, but public are emotionally attached to the visual medias, so they can understand better in depth. So we should encourage more movies related to eye donation. Thank you. Call upon the next speaker, Dr. Anil sir, to come down. Please come over the stage and take over, sir. So I'm really sorry. I request Dr. Vinay sir to come over the stage.
Morning. Well, quite an interesting session. Anyway, after that, wonderful, interesting talk on history, got a lot of new points. Tissue retrieval is the topic that was given to me. This is one of the most important aspects of any eye banking system, as Dr. Hilda mentioned. Now, the tissue retrieval process starts from the time the eye bank receives a call. We have, eye bank team ready 24/7 in all eye banks. What they do is they collect the details over phone, details of the caller, deceased, address, cause of time of death, where the body is, and things like that. And once they collect the information, a certain points, instructions are given to the caller, like it, how to retain, if it is a if the deceased is at home, to avoid direct draft of air onto the face, keep the air conditioner cooler going on, elevate the head end, keep a moist cotton on closed lids or ice packs on the forehead, and things like that. And then the eye bank team leaves to the place where the body is, and once they reach there, the first thing they do is to interact with the family and get a consent. Consent is for two things. One is to collect the tissue, and the second is to collect the blood sample. So after getting the consent, the tissue is actually harvested, and unlike, all people here know that there is practically no disfigurement after you harvest the tissue. So various methods of tissue harvesting is there. What was popular initially was a whole globe harvesting. This is an old video from my SN days. Okay, you get the sample, that is the first step, and then come to the eye. Proper aseptic precautions have to be maintained. How do you enucleate? It's like any other enucleation, 360-degree peritomy, separate, hook, cut the recti muscles, all extraocular muscles, then the optic nerve. You remove the whole globe, transfer it onto the moist chamber or into the moist chamber, then pack the orbit with the cotton and put a single suture. The end looks good without any deformation, disfigurement to the face. So next this is a video which Dr. Hilda has given to me. Now what is most popular, or what is being done, is in situ excision of the corneoscleral button. You don't generally take the whole globe. You take the corneoscleral button at the site itself and then transfer it to the media then and there. Okay, most of the time the media which we use at the time of harvesting is MK media, and then it is brought to the eye bank. Once the excision is done, then you put a shell. Okay, the idea of putting a shell is to prevent the globe from collapsing and extruding the intraocular contents. Once the tissue is brought to the eye bank, then the processing of tissue processing starts. The first step is to give an identifying number to the tissue, and then if it is a whole globe, under lamina hood, the corneoscleral button is excised and then it is transferred to the media, which is most of the time is MK media. Then the tissue is actually assessed or evaluated. Okay, first is a specular microscopy to done the health of counts, all the various parameters of the endothelium, and then a proper slit lamp evaluation is done to know the quality of the tissue, and based on this the tissue is graded, and then once the tissue is graded, based on the grading, it is released for clinical use or for whatever use that particular grade is suitable for, either practice or research purpose. So this is the entire system of or the flow chart of tissue retrieval. Now, one other important point here is to think about the cornea preservation media. I'm not going to the details, just a single slide on various media available. For short term, initially when it is a whole globe, the first thing is we do it to transfer it into the moist chamber, which probably retains it in refrigeration for up to about 24 to 48 hours. Now it is a MK media, which is because we do it, excise it directly. Up to 4 to 5 days it preserves. Then intermediate, what is available now, freely available, is cortisol from the Oro lab, has actually revolutionized the expenditure involved. Okay, up to 10 to 14 days it can be used. So that is all which I have to say, and then the rest of the things will come in the other talks. Thank you.
Thank you, Inesa. That was an excellent presentation with a lot of videos and photos. It helps in better understanding. It was very focused and precise presentation with critical points. I request now Dr. David Putkaran to kindly take over the stage, the topic for gateway ticket.
Good morning, everyone. At the outset, I would like to thank Dr. Hilda and KSOS for this opportunity. I'll be presenting on the topic a gateway ticket, corneal tissue slit lamp evaluation and specular evaluation. As everyone knows, a systematic evaluation and documentation helps the operating surgeon to know the quality of tissue and to improve the outcome of surgery. It helps the surgeon to choose the tissue according to his requirement and depending on the host factors. So prior to evaluation, the details of the donor tissue should be evaluated. The time of death, cause of death, past history, and details of the torchlight examination should be confirmed. The color of the media should be assessed, and tissue should be warmed to room temperature prior to evaluation. The tissue is, the glass bottle containing the tissue is mounted on a slit lamp with the help of a stand, and the features are evaluated. When it comes in a viewing chamber, as in light foci medium, it can be directly evaluated. Routine slit lamp evaluation methods like parallelepiped view, narrow slit, diffuse illumination, specular evaluation, and retroillumination are employed. For the sake of documentation, cornea is divided into a central area, paracentral area, mid-peripheral area, and a peripheral area. Each layer is assessed in detail. Epithelium is evaluated for the extent of exposure, sloughing, and presence of any debris or foreign body. Exposure is a degradation or edema of the epithelial layers as a result of eyelid remaining open after the death. It can be accompanied by sloughing also. In case of mild exposure, only the superficial layers of the epithelium is affected, and the superficial surface, corneal surface, is smooth and regular. In mild to moderate exposure, there will be loss of partial layers of the epithelium, resulting in an irregular surface. In moderate exposure, there will be even more deeper involvement, and in severe exposure, there would be complete sloughing of the epithelium. Sloughing is the absence of epithelium which can result from trauma or intrinsic disease. The percentage of sloughing not coming. Okay. It's come.
There's some technical problem. I hope the team understands that and gives some time extension.
It's come. Okay. It's okay. So epithelium sloughing happens when there is absence of epithelium, which can be a result of trauma or any intrinsic disease. The percentage of sloughing, that is the amount of sloughing on the corneal surface, is documented. Coming to stroma, stroma is evaluated for the extent of arcus, edema, striae, infiltrates, or opacities. The arcus is graded depending upon the clear zone, that is the area which is devoid of the arcus. It is graded as mild arcus when the clear zone is more than 8.5, and severe arcus when it is less than 6 mm. Coming to edema, edema is graded as mild edema when only the anterior layers of the stroma is affected, and mild to moderate when there is extension to the deeper layers of the stroma, and moderate edema when all the layers of the stroma are involved. In severe edema, there will be thickening of the stroma and opacification of the stroma as a result of severe edema. Coming to striae, striae are grayish white lines in the stroma. It can occur at any depth, and it usually coexists with the corneal folds. Stroma should also be evaluated for the presence of any infiltrates, foreign bodies, ectatic disorders like keratoconus, or any dystrophies. All of these are contraindication for utilization of the tissue for any optical purposes. Scars also should be evaluated in detail. The size of the scar, that is the diameter in case of rounded scars, and length of the scars in linear scars should be assessed. The depth of the scars should be evaluated, whether it's in the anterior stroma or into the deeper stroma, and location, whether it's in the central area or peripheral area, should also be documented. The Descemet's membrane is evaluated for folds, any defects or any detachment. Folds, as everyone knows, is caused by thickening of the stroma by edema. Folds are graded as few folds, few to several folds, and numerous folds, depending upon the number and type of the folds. And depending on the intensity, it is classified as mild folds when the valleys and peaks between the caused due to the stromal edema are thinner and shallower. And in mild to moderate folds, it would be even more deeper and wider. The extent will be much more in case of severe folds. Any defects in the Descemet's membrane as a result of surgery or which has occurred during harvestation of the tissue also should be documented. Coming to endothelium, endothelium is evaluated for the extent of stress lines, cell dropouts, and specular evaluation findings. Stress lines are linear opacities at the level of endothelium. These occur while tissue harvesting. When there is folding of the tissue or undue stress on the tissue, there will be rupture of the endothelium or stretching of the endothelium, resulting in stress lines. Stress lines are not much important if it is in the peripheral location, but when it comes to the central location, it can interfere with the quality of the tissue. Loss of endothelial cells are called cell dropouts. These appears as dark areas on specular reflection. Cell dropouts are graded as when mild cell dropout, when there is 5 to 15% of a cell loss in the area of specular reflection. Mild to moderate when the loss is around 15 to 30%, moderate when it is between 30 to 50%, and severe when it is above 50%. Coming to specular evaluation, as shown, specular evaluation is performed with the help of a Eyebank specular microscope. The glass bottle containing the medium is partially immersed in normal saline, and the specular evaluation of the endothelium is done. The details evaluated include the cell density, standard deviation, coefficient of variation, and hexagonality. And from the image, the extent of polymegathism and pleomorphism is also evaluated. So in the first image, you can see that the cell density is 3145 per millimeter square, which is a reasonably good count. And coming to the image, you can see that the hexagonal architecture is well maintained. And the cell size is almost regular, and there is not much of a polymegathism or pleomorphism. Whereas in the second figure, you can see that the cell density is around 609, which is very less, and the image is not clear. You can roughly make out the cell size is grossly enlarged. So there is a lot of polymegathism. And coming to the third image, you can see that the cell count is reasonably good. It is around 2778. But you can see that there is some amount of around moderate amount of polymegathism and pleomorphism. The cell size is increased. There are cell shapes of different shapes. A triangular cell is there. There is a 5-sided pentagon-shaped cell, and some rectangular shaped cells are also this thing. And other information include the presence of jaundice or lens status. This is noted by the technician performing in situ excision. The scleral rim size and regularity is also important because it decides whether the tissue can be mounted on artificial anterior chamber for lamellar surgical procedures. So finally, at the end of all these procedures, the findings of tissue evaluation are noted on a cornea evaluation form. And finally, these details are evaluated by the medical director, and he or she sanctions whether this tissue can be utilized for which all surgical procedures. And final release will be done by the medical director. So when a surgeon receives the form, the main findings of cornea tissue evaluation will be available for the surgeon. The specular evaluation findings also will be issued to the surgeon. So finally, The standardization of the evaluation technique and parameters helps in providing good quality corneas and thereby successful outcomes. Tissue evaluation helps to assess the quality of the procedures ranging from tissue harvesting to the storage of the tissue. Documentation of findings helps the operating surgeon to identify the tissue characteristics and suitability for the surgery performed. Thank you.
Thank you, David, sir, for the beautiful presentation with all the photos in every slide has tailored down this big topic to us in a very nice way. Thank you, sir. I request Dr. Anita Japa, madam, to kindly take over the dais for the topic Path to Eternity. She'll be talking about quality analysis and distribution.
So what is actually happening?
There's an optimum rate for calibration. Depends on the technician who comes for calibration. The set size can be increased, can be zoomed out. The zoom size can be decreased as per the technician's requirement. So if the set size is increased, the set size will be there and the count will be there. If the zoom is decreased, the count will be more.
I think it also depends on the temperature during evaluation. So when it's not kept at right temperature, sometimes the image quality will be very bad. So the cell count might look bad.
That is but you should not substitute a specular with your slit lamp evaluation, because the specular only a small point. Because what you are telling is correct. After calibration, you will get 3000, 3000 plus. CD will be always like that. Good morning. Thank you, Hilda, for your inviting me. And it is very nice to see youngsters like Hilda and Sanjana coming up with the instruction courses. Don't be disheartened with the audience, because so many people are interested in Eyebanking as such. Maybe different sessions are going on, that is why attendance is less. So the topic given to me is Path to Eternity, that is the Eyebank quality control and distribution. So I'll start with as Hilda said, the Eyebank Association Kerala, running in the CBM Ophthalmic Institute, Little Flower Hospital, started in the year 1970 as a small charitable society, and this was the first Eyebank in the private sector of India. Later on, there was infrastructure development, like we procured the laminar flow hood, we procured the intermediate storage media, the Eyebank specular, and the figure shows the evaluation forms, as Dr. David was pointing out. And this is in nutshell, this was the total 23-year collection data starting from 2001 to 2023. From 2000 till 2010, there was the volunteer collection were more, and the HCRP came into being from 2011 onwards, and you can see a steady increase except for the COVID year of 2020. And the changing strategies led to all these changes, like the slit lamp tissue evaluation by the doctors changed into the technician evaluation. HCRP tissue retrieval is being more followed up. Grief counselors in many collection centers, and many collection centers are also started in different hospitals and collection donation centers. Trained technicians are there. A proper SOP was constructed. Accreditation with the big organizations like SightLife was carried out, and there is a central tissue distribution scheme, and now the Eyebank is a more financially sustainable model. So this is the workflow of a general Eyebank. Like these four are the main pillars of the Eyebank. First is the donor acquisition, second is the tissue harvest and the preservation, third is the evaluation, and fourth is the tissue distribution. Not going into details because this has been dealt with in detail. Donor acquisition, mainly the two donor through the voluntary eye donation and the HCRP, and you need the countersigning by the next of kin, and specific documentations are needed. Also for the tissue harvest and preservation by specially skilled and qualified personnel is required, and predefined steps executed in specific order in order to form a surgically acceptable tissues are needed. Then evaluation also, certain criteria, regulatory requirements exist for the test and documentation, and also for the tissue distribution. So tissue distribution, this is the model of tissue distribution followed by many eye banks. They are dividing the priority, the surgeon's priority into three: first priority, second priority, and the third priority. First priority, they call it as emergency priority also. If the patient is having a perforation or impending perforation, or if you have an emergency graft with good visual potential, and also in primary graft failure, they consider this as an emergency priority. Second priority being the urgent priority. If the patient is having pain, and for one-eyed patients and pediatric patients, they consider this as an urgent priority. Third priority is your routine keratoplasties. It can be neither emergency or urgent. It can be a unilateral blindness with good or poor prognosis, and also your elective cases of PK, DSEC, DMEC and all. This comes under the routine priority. And the tissue distribution is according to the surgeon's request. The surgeon should place a request to the eye bank indicating the patient's details, what is the diagnosis, what is the need of the, what is the indication, and the type of the planned surgery, what she or he is planning, and the tentative date of the surgery. And when the distribution is prioritized, wherever the base hospital, those needs are prioritized first, and then if the in-house need is not there, then they will distribute to the same district. That means in Ernakulam means they will give it to the Ernakulam district, and if there is no need from the same district, other districts will be considered, and if there are no needs from the other districts, then the tissue will go outside your state. And whenever the tissue is sent, this type of label will be there on the vial, stating the tissue ID, the time of death, the preservation date, expiry date, and so on. But a set of universally accepted indicators for the quality assurance in eye banking is not available until this article came. Every eye bank is having a paradigm shift nowadays. Rather than collection, more emphasis is given on utilization of the tissues. And this can be used by the usage of the intermediate corneal storage solution, because of the shelf life can be increased, and you can have elective surgeries. From the charity model, the eye banks are raised into a self-sustainable model, and also expansion of the functions like preparation of pre-cut tissue, DMEC roll for the component corneal surgeries. Once your eye bank is established, once you have enough utilizable tissues, you can expand the functions of the eye bank, and also the bioengineered cornea. Many eye banks are working on that. So quality assurance, why is it essential? The quality assurance program is necessary to ensure the timely availability of corneal tissues to the surgeons, to enhance the effectiveness and the efficiency for the safe utilization of the tissues, as well as the infection control. So these are the requirements for the quality assurance and the quality control. A proper SOP is required. Review of the donor records periodically. Any adverse reactions should be noted to the eye bank. In case of adverse reactions, a tissue recall and withdrawal should be practiced. And any departure, deviations, or non-conformance to the SOP, you have to have a CAPA action. That means corrective and preventive action has to be carried out, and also a regular, periodic, internal and external auditing. These are examples of SOP, or the standard operating procedure. Each eye bank should mention in the SOP what are the definite criteria, the criteria for the tissue retrieval, for the evaluation, storage, distribution. Everything should be described well in the SOP, and that should be followed. Review of the donor records. These are examples of the record keeping. The record keeping is very important in eye banking. And also this is the adverse reaction form. This will be sent to the surgeons, and if there is any adverse reactions like infections or primary graft failure, this should be filled up and this should be returned to the eye bank, so that the eye bank can go into the details. And quality analysis and the quality is important in the quality assurance program. And this there are these 4 points: the environmental monitoring, complaints and reporting, performing investigation, and in case of positive serology also investigations. Errors can happen in the quality assurance within the Eyebanks. There are 4 different levels errors can happen in man, machinery, process, as well as policies. In man means sometimes there will be a new fellow or a newly hired staff. They won't be knowing the tissue evaluation properly. So the proper tissue evaluation and the proper contraindication should be mentioned correctly and should be stick to the wall where everyone can see and refer to that. And machinery also, for you have to maintain the correct storage transport chain. Any malfunctioning storage refrigerator can also lead to tissue damage. So the correct internal temperature should be maintained. And process also, the procedure for retrieval of the corneoscleral rim as performed described by Dr. Vinay, and maintaining the adequate cold storage chain during the tissue transport is also crucial. Policies also is very important. Well-established policies and guidelines for the tissue retrieval and the distribution to ensure the maintenance of the quality standards. So I will describe 3 case scenarios where you can go wrong, where you can do this kappa, like death preservation time. So in case we are strictly dealing with the 6 hours time, but in haste somebody will be hearing the death must have happened before time, maybe 16 hours. 16 hours after death, the technician has received a call, and by mistake he has heard 6 hours. So unnecessarily they went to the scene, and that tissue could not be used. But then that investigation should be conducted. And also case 2, medical reports and blood sample collection. Sometimes the team or the technician will forget to have a blood sample collection. So in that case also the serology you cannot do, and that tissue cannot be used. And also sometimes by mistake they will be keeping these tissue vials in the freezer. Then also that will get crystallized, and in that form you should have a kappa, like you should completely, you should have a proper investigation of what has happened in each case. So the continuous quality improvement can be achieved by identifying the implementing corrective actions, develop policies and guidelines to prevent recurrence. Once happened, it has happened, but you have to develop policies and guidelines to prevent the recurrence. And good clinical practices can be established, ultimately benefiting the patients. So these are the quality indicators which are mentioned in this very good article by Manisha Acharya. The 4 quality indicators for Eyebank are the adverse reaction rate, the discard rate, protocol deviation rate, and the compliance rate. Thank you.
Thank you, madam, for the extensive presentation with all the beautiful points. The complexity of the topic has been broken down and very clearly explained. Thank you, madam, once again. I request Dr. Anil Radhakrishnan, sir, to kindly come over the stage and start the topic with Beat the Defeat. Sir will be talking about conquering the challenges of Eyebanking. And this is the final topic.
So Hilda, when are we supposed to leave the hall? 10:30, 10:25? Okay.
Sir, you have all the time till 10:25.
No, not that I need a lot of time, but I have a query to Anita or somebody who's running the Eyebank. See, basically, sometimes Eyebank will evaluate something and then they will send it to you. So when you evaluate, you don't agree with them totally. Even if you take it out of the moist chamber and keep it outside, and then they would have written few folds, but you see that the number of folds are more, and you feel very hesitant about using that particular tissue. So what's the best course of action?
Everything will be depending on the surgeon. It is under the discrepancy of the surgeon. You can reject a tissue, you can send it back, because maybe that tissue must have been evaluated very soon after the retrieval. So there won't be any folds. But once the tissue reaches you, maybe 1 or 2 days must have been lapsed, and it must have created the folds. Okay. So you don't go for the entirely, you depend, before each case, you take out the vial and depends on your surgeon's discrepancy.
Madam correctly said, in our Eyebank, the evaluation will be done right after the retrieval. It is in the right initial phase, so probably the folds are less. So by the distribution, if there is a delay of 1 or 2 days, the folds will be formed. And the final decision is always a surgeon's decision.
Okay, thank you. Yeah, so I generally I usually reevaluate the tissue after 24 hours. But quite often it seems that the quality might improve, sometimes it will go worse also. So I don't know what exactly is happening, but sometimes it becomes better, sometimes it is worse. Okay, so the topic Hilda has given me is to beat the defeat. I would say we have been defeated so many times. I don't know whether I'm capable of telling about how to beat the defeat. So this I'll skip. Corneal diseases form the second major cause of blindness in the developing world. It's the estimates of blindness varies from whichever studies you look into, but the projected estimate is close to about 12 million, and about 275 million have vision loss. So this interesting study, the National Blindness and Visual Impairment Survey conducted by multiple centers from 2015 to 2019 found that the blindness has reduced from 1.4% to 0.36%. The original target was 0.3%, but we are very, very close to the target, which is really commendable. So the cooperation of the private and the public sector to work in these lines for this NPCP, that has really worked well. And we should understand that cataract is the major cause even now. But we now very well know that the cataract surgical coverage is close to 94%. Cataract surgical cover means a number of people who require cataract surgery who can access the services. So if 100 people require surgery, 94 people are able to avail the opportunity in a country like India, in which the financial constraints are very much there. So that is really commendable. So now it is the opportune time to look beyond cataract and look at other pathologies. So the most prominent pathology that we have is the corneal pathology. So corneal blindness, as people have multiple times mentioned, that it is about 0.45% of the population in people more than 50 years. And in people between 0 to 49 years, it is 37.5%, which is the most common cause of morbidity. In the rural scenario, the situation is slightly more. The corneal blindness is 0.55% and bilateral blindness is 0.12%, which is really, really significant. So I'm not going into the details of the eye banking. Hilda has very beautifully mentioned about it. So before 70s, it was limited to Gujarat alone. But now we have about 740 registered eye banks. So a sea change has happened after the 70s. I think a lot of it happened because thanks to the institutions like Aravind Eye Care System, Shankar Nethralaya, LB Prasad Eye Institute, who revolutionized this field in our country. So at this point of time, we require about 270,000 donor eyes to perform about 100,000 transplants every year. This I made a mention, NPCB, we were the first country in the world to launch a national program to reduce the blindness, and we have almost achieved it. But the interesting thing about the eye banks is that the 2% of eye banks constitute to about 70% of the collection, which means that a very significant percentage, 90% of them are non-performers. With the coming together of Side Life and EBIA, things have improved better. But India as a country needs better infrastructure. Even though the infrastructure and readiness is high, it needs a strong nodal system and a monitoring agency to really take it forward. So if you look at the eye collection numbers, the maximum possible collection which was happened in India is in 2017-18, 71,709. And utilization was about 26,682. If you look at the last year, the collection was 45,008, almost 46,000, and the utilization was around 28,000, 61% utilization. So we have really come a long way. I think there are about 500 active corneal surgeons in India. I think Corneal Society, Binay must be knowing better, has close to 1,000 people. So if every surgeon does 100 cases a year, easily all the corneal blindness can be taken care of. But I think the transplants are limited to few major institutes. LB Prasad runs about 4,000 per year. I think I'm talking about the Hyderabad Center. I think tomorrow they are having a program because they have completed 50,000 transplants. Aravind are having 1,400 per year. Shankar Nethralaya around 650 to 700. So certain centers are doing exceptionally well, while most of the other centers are not doing well. So why are we doing transplants? So I think if you look at the image, you can see that it's predominantly infections even now. Even though the infections have plateaued after say 90s and all, but still it is the predominant cause of the transplant. The other major causes are endothelial disorders, which is steadily going up. The number of regrafts have taken a dip after the coming into prominence of DSEK and DMEK. So regrafts, the numbers have reduced. Corneal scar also, it appears reduced. Maybe it is related to the better financial circumstances that we have, while others are almost same. So even now, infections and scars take a major role. So in general, voluntary eye donation, it is seen that in India, the utilization rate is about 20 to 28%. In HCRP, it is about 50%. In the largest eye bank in Asia, that is Ramayama International Eye Bank attached to LV Prasad, it's about 70% HCRP. In LF, I believe it is 35%. So that is regarding the gross numbers. When you say GDP of India is great, you have to look at per capita also. So we should look, when we look at the corneal transplants that is happening in every million population, the global average is only 10. 10 transplants are happening for a million people. In India, it is about 23 million. While in US, it is close to 199 per million. That is very, very high. While in Europe, it is around 55 to 75. So most of the developed countries, it is between 55 to 75. That is most likely the figure we should be looking at. And India, we have almost half of it, less than half of it. And regarding the procurement, we have become much better, but the global average is 25 in million, and India is about 30 per million. So we need a fourfold increase in the procurement. We need a fourfold increase. So India is ranked as almost sufficient, ranks second to US in the numbers, both in procurement as well as transplant. This is a gross map of the world, in which India has reached the green category, in which it is almost sufficient. But if you see US and if you see Sri Lanka, which are blue, they are mass exporters. So we should think of that, because the resources that we have are tremendous. So the small story that I have regarding the Amrita Eye Bank, I think we started in 2011. In 2012, with all Josh, I started the HCRP, and found that a lot of people, most of the corneas I could not utilize at all. So utilization was only 27%. So the reason why, so I was looking at it, so most patients were on ventilator, because it's an Apex Institute. People who are nearly dead only come there. So most of the tissues are damaged. And so which made me more selective regarding the donor selection. And then selective HCRP was done in that period. And so we used to collect about 50 eyes. So in 2018, we tied up with Saksham, which is a voluntary organization, which has a pan-India presence, which works on the field of disability. And then we started the voluntary eye donation. And there are people like him, Ramkumar Madathil, who was on his own, has motivated about 200 corneas to 200 people to donate their eyes. So over a period of 3 years, we are, last 3 years, we are consistently getting about more than 100 eyes every year. This organization, which started in Ernakulam, they are doing it in Kottayam also now, which is mostly given to Chaitanya Eye Hospital. I think few corneas in Cornea goes to Giridhar as well as the Eyebank Association of Kerala, but I think Eyebank Association is way, way ahead of us. In Calicut also, they have made in collaboration with the NIMS Hospital. So this is, I think Hilda has already mentioned about this. But if you look at star performers like Eyebank Association of Kerala, I think they have retrieved close to 2,090 corneas and utilized about 984. And a voluntary donation is 670, and HCRP is about 314. And if you look at super performers like Ramayama Eye Bank, they have, I think all the LBPI banks together, they have 10,000 tissues they do. I think keratoplasty numbers around 2,500 every year. And they have done a total of 35,000. I think tomorrow there is something which makes this landmark of 50,000 keratoplasties they have done in the last 35 years. So eye banks need a 3-tier system. One is the eye donation center, which can be attached to an eye bank. I think Little Flower Hospital Angamali has really demonstrated they have multiple eye donation centers which mainly work on HCRP, and this eye bank has to. Eye bank is the place where we evaluate the tissue and distributes it to the surgeon. And we should have a few centers of excellence which can be eye bank training centers. So I would. I think I'll take one more minute.
So it's okay, you can continue.
Yeah,
We don't
yeah.
have a discussion.
Okay, fine. So the main challenge, as Dr. Samar Basak was telling, is the data gap that we have. We have, I think, till my time of post-graduation, I've been learning that every year there is about 1 lakh backlog of corneal blindness that we have, and about 25 to 30,000 gets added every year. I don't know exactly where this information is from. Anyway, it is more than 25 years old. So if you look at only bilateral blindness, there is people less than 3/60 vision in even the better eye. If you just take that number, it is close to 4.2 lakhs. And we don't know exactly how many of them are transplantable. So they may be having vitamin D deficiency and a globe collapse, and they may be having a deranged posterior segment, in which case it is not working. So we do not have exact data regarding that particular thing in India. So the challenges in eye bank is, I think what I mainly see is the statistics. Second is the socio-cultural perceptions, which have changed a lot in the last 20-25 years. Tissue supply again has improved. There is much more way to go. Tissue retrieval again has improved significantly with the incorporation of eye bank technicians. There may be better things that you can do with policy support. Like if you have if you can notify the large eye bank nearby that a death has happened, it will be something great, and no tissues will be wasted. And now I think we would have seen, people who are in the eye bank field must be knowing, regarding the tissue distribution, there is going to be a national waitlist registry in conjunction with the Eye Bank Association of India, NPCB, and the NOTO, that is the organ transplant and tissue transplant team. So this may become slightly unprofitable for the private eye banks. So we have to really work hard to make sure that we can exist. There can be some policy and advocacy from the government side also. For example, the Central Motor Vehicle Rules Amendment. Even now in the Kerala driving license, when I changed it, there was a question whether you are willing to donate the eyes, which is a step in the right direction. So I thank you so much for the opportunity once again. Hilda, it was a very good session, even though the attendance was not justifying that.
Thank you, sir. It was a very tough topic, the challenges to be faced, and sir has given a dramatic presentation with extensive statistics as well as the points which we can improve. The main point what sir focused was the gap in documentation. India being a vast country, there's a lot of gap in documentation. We need to document about the surgeries done. It also helps in database analysis, and also the cultural and social involvement. And 2018 Act of the Motor Vehicles, we have to get it in action in every state, which helps in further promotion of eye donation. Thank you, sir. Any questions for discussion? I was just worried whether we'll end at time, but I'm very happy that it ended at the right time. And I think only the cornea people involved in eye banking are there, and no more doubts. I thank once again Vinay sir, David sir, Anita madam, and Anil sir for the beautiful presentation.